Alrighty, hello and welcome to another episode of the RCPA's Pathology podcast, the Pathology Report. My name is Ian Gassiep. I'm a clinical microbiologist at Pathology Queensland and an infectious diseases physician at the Mater in Brisbane. We have an excellent panel today discussing the topic of sepsis. We have Dr. Dawar, Dr. Peck Palmer, and Dr. Sikaris. I'd just like to ask them to introduce themselves first.
Thank you, Ian. I'm Dr. Niti Dawar, and I work with Roche Diagnostics Australia as Senior Medical and Scientific Affairs Manager. And I'm a chemical pathologist by my training in previous years, but I've been working in the industry for last 8 years now. Thank you.
Thank you so much for having me. My name is Octavia Peck Palmer. I'm a clinical chemist and division director of clinical chemistry at the University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania. And so, I find that all of the work that's being done in the clinical laboratories really plays a central role in patient care.
Thank you.
I'm Ken Sikaris. I'm a chemical pathologist in a private community lab in Melbourne. We test about 10,000 patients a day, mainly from primary care, and I've been practicing for 30 years or more.
Yeah. Right, welcome. Well, look, I mean, I think our audience is probably well aware that sepsis is a critical health issue. I did really enjoy, Dr. Peck Palmer, your talk, and just to talk about some of the stats, you mentioned that there was almost, I think, 49 million episodes of sepsis worldwide. I believe America's at 1.7 million episodes. That overall is about 10 million deaths worldwide, which is phenomenal numbers. Australia, I think we're at about 55,000 cases per year. We're looking at about 9,000 deaths annually. So really, really big numbers, and clearly a reason why this is such a critical topic. So it's great that we can chat about this today. So the first question is going to be relatively general, and I'll start with your response, please, Dr. Peck Palmer. But can you please chat to us about how you see or how you think the laboratory can help with, the early detection or diagnosis of sepsis?
Yes. So I would say there's two paradigms, one of which is what we can do in real time with clinical results, but also there's a second part, which is clinical research, which we should be a leader in. So the first one is really understanding, do we have the menu that's responsive for our patient population? And is that menu available to be ordered so that you get the various tests that have sensitivity and specificity to let you know that there's organ dysfunction, but to also let you know that there is an infection? The second part of that is research, and that being we generate a copious amount of data. And what we can do is to start enrolling individuals in what we've done, in my collaborators, Dr. Seymour and Dr. Kim Morrell, have demonstrated that you can virtually enroll patients who we believe have sepsis using the residual specimens on patients. And then we start to see those patterns that the patients have who actually end up having sepsis and ultimately the morbidity and mortality. That way, what you're doing is customizing the type of infection that you're seeing in your community. And from there, we can start partnering with in vitro diagnostics to build out more diagnostic tools that encompass not just one biomarker that's non-sensitive, but a host of biomarkers that are working in concert together that give you that pattern of those patients. So it's a clinical data, making sure you have the menu that's responsive, getting those results to the physician in a manner that they can read them in a user-friendly manner and a timely manner. And then secondly, us going back and looking at our data that we have on the patients that we're actually taking care of.
Thank you. That's really interesting. I'm going to segue into that biobanking part that you talked about because I'm really interested in that. But before we get there, Dr. Dawar, anything that you would like to add to this?
Yeah, definitely. I think Octavia has mentioned very nicely about holistically how the care should be. But coming from the industry, I would like to elucidate a little bit more on the biomarker side of things. Since sepsis is a continuum, it's a syndrome, it's a complex, physiological, pathological, and biochemical syndrome, I may say. It's not a single disease. Mm-hmm. That's why, having those targeted biomarkers is a big challenge. And I absolutely agree with you on the clinical research part of it. It has to go in hand with the clinical part because sepsis is clearly lacking in, having a clear targeted biomarkers because of the nature of the disease. Mm-hmm. But there have been so many clinical trials. Some of them have failed. But then, yes, let's not lose hope and keep working on it as a community, as a clinical community and as a lab community. I think it's our responsibility to have greater impact on these patients by, producing and investing more in R&D in such biomarkers. So there are a lot of biomarkers which are new, some old, and still the clinical utility, some of them, awareness is lacking for some of the old biomarkers. Yeah. So I do see a segue of between, R&D and education also, and raising awareness is really important for the existing biomarkers for which we already have normal reference ranges and cutoffs. But there are so many new which may not be available in all hospital settings. That is access comes into picture. Yeah. So I see a lot of things interweaving like education, access, R&D, since it is so complex that the whole landscape needs to be involved, and we as a community, clinical community, really need to work on it.
Yeah, so you made an interesting point there about education, right? So it's fascinating because we always talk about awareness and education and having awareness of the septic patient. But then that's a really nice point that you made about, well, there's actually potentially a lack of awareness about the correct test to order. So now you're missing two key parts of awareness. Yes, you might be able to think about the right test, but not the right patient cohort, or vice versa. So that's really interesting. So let's stick with that theme of biomarkers because, clearly is topical. And Ken, would you like to chat about what your thoughts are? I mean, there's lots of biomarkers. We were chatting offline earlier about things like CRP, procalcitonin. What are your thoughts?
Yeah, there's quite a few. I mean, interleukins and CRP and then the cell changes. One of the things about them is they're sort of sequential. You have to understand the pathophysiology. So some of them aren't elevated in the immediate case, and some take too long to rise. The place that I think that's really important is in primary care, because with community sepsis, the primary care physician, if he orders the test, he's not going to get the results in 1 or 2 hours from a community lab. And so I think that there's a challenge there because the guidelines really apply to hospital settings and the community settings. As soon as you suspect sepsis, it's almost like AMI, the patient should be being assessed in a tertiary setting.
Yeah.
And we do have problems. All private pathologists would know. We get sort of CRP levels of 300 or 400 after hours, and the patient's got a note query sepsis.
Yeah.
And it's like, and we can't find the doctor and everything. And it's like, it's too late. It's like, we hope they're on antibiotics, even though the clinicians may hope they're not antibiotics, so they can get the blood cultures off antibiotics. Yeah. So there's the setting really determines the value of the biomarker as well.
Yeah. So I mean, that setting thing is interesting for a number of aspects. As you say, it's a different practice point to begin with, but also it's access, right? So it might be that the CRP, which we can discuss a little bit more in a second, and I will throw that to you, Dr. Peck Palmer, but it might be the only test that's available. It might be that particular location doesn't have a procalcitonin, doesn't have, any other ability to do what we might consider fancy diagnostic tests. So, I mean, okay, let's segue into the combination of biomarkers, but let's include a little bit of access, and then I'm going to lead that directly into the bigger picture of access when we talk about disparity in health, because it seems like you are what appears to me to be a world expert in that particular area. So let's start basics, biomarkers, even simpler. What are your thoughts on, say, CRP, procalcitonin tests that are more comparatively readily available at the moment?
Yes, so I would say none of those are biomarkers of sepsis. And we talk about what a biomarker is. I would say that these are mediators that are released within the bloodstream that we can measure, that are part of the concert or the pathophysiology of sepsis. And so thinking about, our 2013 definition of sepsis with an associated organ dysfunction, the laboratory can do all of that. We can measure these mediators that are expressed. And also, sepsis is not sepsis. You can have different etiologies. So someone may show up with sepsis due to a surgery that they had where they got an infection from their knee, or they can have sepsis from the community, as Ken noted. And so it started out as a lower respiratory tract infection, and now has moved on to become sepsis. So I think the bigger picture for us is understanding what those clear cutoffs are in those patients that present. Also, as Dr. Ken noted, they're coming from their primary care physician. He only had or she only had CRP. That's a nice standing point, but CRP can be non-specifically upregulated. But not having that patient then move on to be seen because access barrier, geographical, maybe insurance wise, we're doing a disservice. So the goal is, how do we roll out some of these diagnostic tools into rural areas and make them complete, not let having just one marker per se, but let's find ways to make it economical, accessible, so that you have in your primary care physician, you have that instrument that is accurate and timely, that can give you a better picture of the hypo response that the patient is undergoing, and then put into play who's going to see that patient next. So that information, I think a lot of the information that we have from ambulance, from primary care physician, is not uploaded into an EMR. And so we're missing. That's another way that it's inequitable care, because the data is not there. It may exist one place, but it's not where it needs to be at that time. So yeah, I think that all the comments that both of my colleagues have just noted really add into the point of, we have diagnostic tools, but we need to know the cohort to use them in, Dr. Niti noted, and we also need to know how to understand and interpret those results.
No, that's great. I'm so glad that you kind of reiterated that the CRP in and of itself is not a specific marker for sepsis. How many times I've had to explain this, I'm sure you've had to as well, that, so many different variables can result in the inflammation, right? So, okay, well, let's just keep that train of thought going. I'll go back to you, Dr. Dawar. What would you're coming from the industry perspective. So we're talking about, let's say, horizon scanning. Now I'm segueing into somewhat semi-futuristic thought processes here. What do you see as the next potential biomarker or combination of biomarkers or analytics that can help with narrowing down that patient population, increasing sensitivity and specificity?
Yeah. So no, that's a very good point. So I think from a futuristic point of view, as Octavia also mentioned, there's no one complete solution for it, like no complete biomarker. So there are various data points when if you see from a clinical perspective as well. So there are a lot of data points when the clinician first sees the patient. So, the age, the medical history, the lab tests, and signs and symptoms, vitals, it's a total picture. So with all these data points, the thing that comes to my mind first is modeling, algorithm, and AI, taking help of AI for computing, for doing this data analysis, bringing all that amalgamation of data and generating insights quickly, because time is of essence in sepsis, right? Yeah. With every 1 hour of passing, there's increase in mortality by 7.6%. So keeping time in mind, I think it's important to take help of the growing technology, the game-changing technology and AI. Yeah. And somehow when I, think about how about the interpretation of these data, definitely human intelligence also plays a part in it, But then the clinicians can take help of this modeling, integrate into clinical decision making, and then, really have that interpretation of the whole data very quickly and result in, saving time and linking patient to care very quickly. First part is diagnosis, then triaging, and then assessing the severity, and then the therapy guidance. I think all can be expedited, and we can have better results and better impact, and lesser morbidity as well as a result of sepsis. That's what I think about it. Yeah.
I mean, look, if we just move on from the CRP kind of discussion and just go to the next kind of available test, which is the procalcitonin. I think from my perspective, for so many years in Australia, at least in my practice, procalcitonin wasn't available. It was a very expensive test. The turnaround time could be 48 plus hours. Now that's improved, but we've heard from people today, and yourself, Dr. Peck Palmer, talking about to some extent the pros and cons of procalcitonin. Ken, is that something that your laboratory is performing large volumes of?
No, not. Essentially because it's an out-of-pocket cost in the Australian sector, and the patients don't see the value on it, that it's not available. And it's a pity, because whilst, say, procalcitonin might cost an order of magnitude more than a CRP to perform, the cost compared to unnecessary hospitalisation or morbidity is insignificant. Yeah. And so these arguments need to be made to the reimbursement controls to say that these tests are, if they are more useful, which procalcitonin is, it needs to be available.
Yep.
On that point, I totally agree with this focus on AI. We've got so much information on patients, or end organ effects, the inflammation, any microbiology. One of the things that both the FDA and the TGA require in AI is that it's transparent in its logic. And this is important clinically, so that the message to the clinician shouldn't be like the patient has sepsis. It should be the patient has sepsis because I have this evidence and end organ damage and so on. And then the clinicians not only can judge that evidence in the light of the information that we might not have when developing that recommendation, but it engages the clinician in the whole issue of that specific patient and what these results mean in their setting. So I do think that that's not far away. US has got the HL7 setting, the interoperable data. This data is really just sitting there for us to manage that informed clinical decision guide.
And just in January, U.S., we do have an FDA-approved sepsis tool that utilizes machine learning. It will tell you if it's a viral infection or a bacterial infection. While we've not used it personally in our own hospitals, it does engage with the clinician of saying the risk at which or the likelihood at which the severity of the infection is associated with sepsis. So it'll be interesting to see how different hospitals are able to utilize this machine learning. There's about 29 genes that are detected in this assay. So it'll be interesting to see, is it associated with positive outcomes? Is it associated with early detection? And then downstream, how does it really impact the quality of health of the patient after they've actually had a bout with sepsis? So I agree with you that we've got to take advantage of the data that we have.
Yeah, absolutely. And the things that we should keep in mind is, clinical validation, as you said, that now since you will be practicing it and your experience and that real world experience, and I think sharing cross borders is so important. So important. Collaboration between the countries is really important at this point of time. So we can just tackle this problem, globally. Yeah,
Ken, I liked your point about the kind of context specific nature of the results. And that leads me to the sort of slide that you had, Dr. Peck Palmer, where you had, I'm pretty sure it was your talk, the sort of patient data on the left-hand side with their, observations. And then on the far right-hand side, it included all their laboratory information. So that's kind of a one-stop shop for everything in one place. So that to me is the perfect kind of contextualization. You have the clinician opening up a chart and seeing within 30 seconds this person's temperature, heart rate, saturations, then immediately seeing what's their lactate, if they have a CRP, if they have a procalcitonin, all of these things, what their renal function is. So not only are they working out their SOFA scores, but they're also then thinking, well, I can work out what the dose needs to be, right, for that drug. Yeah, I really quite enjoyed that. I mean, the one thing I would say there that would be slightly not concerning, but an issue would be, again, access, because I suspect not everybody would have that particular, electronic system. I know in Australia, that's a particular problem. Not only do we not necessarily have electronic systems in every hospital, they're different, which I assume that's similar in America. You're working off of different systems?
Yes. So fortunately for us at the institution that I'm at, UPMC, we're actually upgrading our system. And that is because for quite some time, similar to other hospitals, you've made these revisions, you've updated, but you've not done that across the system. And I think this is going to actually aid us in ensuring that everyone is getting the same information at the same time. But also it gives the ability for the ordering physician to find test orders accurately, also know what was done in a point of care setting versus in the main lab, what hospital was done, and in our case, which vendor we utilized to perform the testing. So that is something I think is shared globally, of laboratories not being on a standardized system, but we're getting to that, and hopefully in 2026 we'll all be on that same system within our large healthcare organization.
That's awesome.
Yeah.
Okay, so there was one thing I want to pick up there. You mentioned the phrase, the key phrase, maybe, point of care testing. Now, I suppose that to some extent it's controversial because it depends on what the person's particular definition of point of care is, but then also what we think the actual utility of the test that we might be talking about is. And I'm not going to use CRP as an example to, flog that dead horse. But I mean, contextually, I'll start with you, Ken. Point of care generally, do you see that as something where it might actually be relevant in the setting of sepsis, or do you think in the Australian context it's not necessarily that critical to our kind of healthcare system given our current infrastructure?
I think point of care, both point of place and point of time, is really important in primary care to have results immediately. The other thing about point of care which differs in the laboratory is that the analytical standards are quite different. We're not really interested if the CRP is 5 or 4 or, ultra sensitive, or we're interested in if it's like 200 or less than 100. And so the point of care tools can be very useful in that setting, especially for triaging these patients who should be heading to hospital straight away. The problem is that, we have an accreditation standard for laboratories and we try to apply it to point of care, and it's really quite unfair because, it's a very limited instrument and, limited reagents. You can QC the reagent and the instrument relatively simply, and you can have point of care that works. So I think with time, as we appreciate which tests would be more valuable up front, the point of care, the business case for point of care will improve.
Yeah. I mean, to some extent, the lactate is a point of care, really, isn't it?
Well, that's right. But so blood gases are relatively easy. The iStats do blood gases, and clinicians. Primary care GPs don't have access to it, but community health services certainly do.
Yeah.
And that should be an alarm straight away. And the bicarb's low. What was the lactate? Was it measured? There should be a profile, really. If you query sepsis, that point of care instrument should give you all the information, and ideally with a bit of an interpretation, because
right, there it is. That's for Roche to create for us. You've heard the wish list, but I will go.
Yeah, I would like to, just add, you elucidated everything, but then what we have started calling point of care is now near patient care. Mm-hmm. So that's the terminology I've started using. So that's absolutely essential in some settings, especially in Australia, the geography and, big countries where we have those population communities who are, too far away from the cities, and it's really important. And again, the second point for point of care or near patient care is time. Time is of essence. And same as for sepsis. I do see real value in having, most of these biomarkers in point of care settings. Mm-hmm. Definitely QC and all validation is a big issue. And another issue that we challenge as industry is getting reimbursement for point of care. They require so much data. The TGA requires so much data, and they are absolutely so much data is required, which we are not able to fulfill at many times. And it is a long process. It can take 7 to 8 years, if I may say, and the test might lose its value by the time we get it reimbursed. So that is another challenge on top of the QC that we face, decentralized testing. So it's very difficult. Once you're sitting in the lab, everything is accredited, everything is validated, but once it is decentralized, that is a challenge. Yeah.
And so I'm hoping that segues nicely potentially into Dr. Peck Palmer, some of your work with biobanking or the biorepositories. Do you have any kind of projects on the go or anything in the near future where you would be using those biorepositories specifically for point of care or near patient type testing?
Yeah, so my colleague, Dr. Chris Seymour, who's at the University of Pittsburgh School of Medicine, and he is a sepsis expert, with also the chair, Dr. Derek Angus, who has been doing a lot of work in epidemiology of sepsis and really is an expert too. I say out to say that they've built this infrastructure with the clinical lab and has brought us in as collaborators. And so what I showed in my earlier talk was the ability for us to collect those residual specimens on individuals that were selected based off of our electronic alert that fires off for sepsis 3. And the paper that was published really demonstrated the feasibility of using those specimens. The transcriptomic data demonstrated that lactate is changing in these patients, along with the host of coag and hematological parameters. But what it also shared is that we could also detect microorganisms that are translocating to the gut. So getting all that information allows us to see the patterns of sepsis that we're actually seeing, but it also helps us work with industry. It helps us to understand too what other markers should we be coalescing together in a machine learning fashion for our patients. the key that I would say about that, less than $40,000 to run this, a way that we could collaborate. We could have hospitals from Australia query their data. We could be pulling the data from the USA, and we could be really looking at real-time data for these patients. So we all could be in the business of biobanking these samples that are stable, that will be thrown away anyway, and that won't take the 6 to 7 years, because we're putting that on industry to do, but we could really center the lab to say we're part of this in a true collaborative method, and we can start to bring out these informative markers for various types of sepsis. And so we're at that point right now. We just need to do it. And we have the data, and it's a virtual clinical trial in itself, and you're enrolling and you're representing individuals that are at least coming into your hospital. So true representation.
And that's exactly what I was going to next, was the representation, because again, having listened to a few of your talks now, a few things. One, I would like to highlight again that I was very happy that you specifically mentioned that race is not biology. Because again, you read trial after trial where they've separated by race, and clearly that's not biological plausibility, but more just socioeconomic association. But yeah, talking about diversity of samples and diversity of sepsis, we had a chat now, obviously, at our last presentation, where we showed some of the Australian data that showed that the Aboriginal and Torres Strait Islander rates of sepsis are double that of the non-Aboriginal population, and you had presented some very interesting data which was quite similar in America. And the one thing that actually I knew about some of the pain-associated biases that clinician has with regards to black people having a, inverted commas, higher pain threshold. I didn't know about the immune system one, which is fascinating. So I was thinking, I wonder now what repercussions that has in Australia and other countries where the assumption is that somebody comes in, they're in septic shock, but they're stronger. Which is fascinating. Could you chat to me a bit more about that kind of diversity aspect? I know it's a huge topic, but I'm just so fascinated by it.
Yeah. So what's really clear is that we all have biases, and biases do protect us. Okay. But there are ways in which we use our biases that actually are making people sicker. And so just as you noted from that study where they had queried first year, second year, third year, and even residents, these are medical students and then residents, do you have these thoughts or beliefs about black versus white? And we could put any other racial ethnic group in there and see those ideas. But the thought was, yes, that we believe that they have a higher immune response. We also believe that they have thicker skin. So imagine, as a pathology in a lab perspective, if you believe those things, then the way you develop your reference intervals will be to query and say black versus white patients have to have different reference intervals. If you believe those things, you may change your practices of phlebotomy because you believe that you have to take blood a different way for these individuals. And then that's what we lead to distrust. We lead to traumatic experiences with healthcare, and then we don't have follow-up of care for those patients. So it's very important that we move away from using race as a proxy and start to identify those social determinants of health, just like you noted, the socioeconomics. Because if you make an assumption that one of us here can't have a disease because we believe the disease only can be in one patient versus another patient population, then you're delaying care. And when we've seen that, we have the studies, we've demonstrated that. And so it's time for us to really unlearn what we've learned. And it does start with our medical school curriculum. It starts with us as practicing individuals in our own right to figure out where those biases, where they exist. And once we start doing that, it just becomes second nature. It's not a health equity focused or a ping of a word, a catchphrase. It's really how we deliver care. How do we do and design our studies to ensure representation, and why that's so important.
Thank you. That's an awesome answer. I mean, look, I think I'm going to start to wind up here. We have been chatting for quite some time. This has been fascinating. We've covered a range of topics within the sepsis kind of umbrella. Sort of final thoughts. Anybody like to add to what we've discussed today? Is any burning questions, thoughts, comments? Ken, anything from you?
But following on from that point, I mean, the fall in EGFR and the EGFR equations have been, we've been encouraged to have race adjustments, but it's almost against the principle of personalised medicine that you should be adjusting for race. You should be adjusting to the individual. Yeah. And that's where we hope to be. Yeah, no, very good point with the EGFR. That's fascinating. I mean, there was a really interesting transplant-associated, outcomes or lack thereof because of the EGFR
Dr. Dawar?
For me, I think most important thing is collaboration between the different communities, the clinicians, labs, industry, and also having representation from underserved population and working with those organizations in order to have community-led programs, because we might be missing on so many people in the community who are underserved, and we need to address that disparity as well. So I look forward to collaborating with all of you.
And then final word, Dr. Peck Palmer.
It encourages me that we are taking a new lens at how we do everything that pertains to healthcare. And again, unlearning what we learned to be true, but doing what we said we were supposed to do, deliver personalized medicine, not population-based medicine. So this is so encouraging to me to see how we're moving forward to deliver care.
Thanks very much for your time, guys.
Thank you. Thank you so much.